maybe a bit loud, because I'm totally loud actually. Yeah. To understand the implant soft tissues, of course, we have to go back a little bit in the biology. And I would like also to ask you to translate her, if this is okay. If I'm not, it's okay. So we need to go back a little bit into the biology and understand the anatomy. I'm sure you're familiar with that, but you know the biology with the anatomy parameters of tissue. This is different from a tooth, and the overall thickness, the vertical thickness of these soft tissues, it's about 3 to 4 millimeters. This is a little bit more than a natural teeth, and the interface is in the most coronal part. This is an epithelial adhesion. You know, this is epithelial cells that are connected to the transmucosal component or to the neck of the implant, if it's a tissue leveling, with any disc. And then in the most apical part, this is connected. But it's a connective interface, but it is not the same as a natural tooth. It is an adhesion as well. You know, we don't have the fibroblasts or the collagen fibers strongly anchored to the components. Yeah, let me take the microphone maybe. Okay. Oh. Excellent. The apical part, connective tissue. This is not an anchorage like the shower fibers, like on a natural tooth, but this is like a connective adhesion. And if we go a bit more into details, comparing these two interfaces between an implant and a natural tooth, first difference is the vascularization. We have less vascularization, less blood supply with an implant, because we don't have the blood supply coming from the ligament. And another difference is how this connective tissue architecture is organized. You know, on a natural tooth, you know well that we have an anchorage of the collagen fibers perpendicular to the cement, and we have a kind of strong attachment. And around an implant, this is more parallel, this is not so adherent, this is not an attachment actually. And when you probe, actually, you go a lot deeper. And when you probe around the tooth, as soon as you touch the ligament, then your probe stops. And here I have wonderful images from Peter Schubach. He's one of the best biologists and has strong expertise in implant dentistry. And this is actually cell images from a tooth, and we really see the collagen fibers being anchored in the cement. And here, this is the interface around a dental implant. So what you see here, this is the titanium surface, and here this is the collagen fibers that are just parallel to the surface, and you see that it's easily detached. So basically, what we have to keep in mind is that around an implant, you have a fragile adhesion. Why? On a natural tooth, you have a stronger attachment. Okay? And then the next question is, then what's a But basically, if I come back here, in order to compensate this weakness we have with on the implant, we will have to cheat a little bit. We will have to compensate that and try to optimize the peri-implant soft tissue environment. But first question we can raise is, what is an optimal, what is a proper peri-implant soft tissue environment, right? First, we talk a lot about the keratinized tissue. How much keratinized tissue do we need around the implant? Do we actually need keratinized tissue? And obviously, when you look at this picture, you see that we have quite a lot of plaque accumulation, and actually there is evidence that with less than 2 millimeters of keratinized tissue, we have more plaque. Plaque means inflammation. There is also evidence that there is more inflammation if you have limited quantity of keratinized tissue. This is not on my slide, but there is also evidence that there is less comfort for the patient. Less comfort for the patient with less than 2 millimeters of keratinized tissue. And then this is where it is a bit more controversial, is there more bone loss? There is no evidence about that, but if there is more plaque, more inflammation, we can expect that we will have more loss. And also, the interface with the components, the implant components, would be, under the pressure of the muscles you just have under the alveolar mucosa, and then you may have like more mechanical opening of this interface with the adult. So a little bit like around natural teeth, I would recommend, and now this is I think pretty much accepted in our community, that the ideal is to have at least 2 millimeters of keratinized tissue on each side of the implant. Meaning that we would need, from when we start from the beginning, like 4 millimeters to have 2 on each side, right? Now, the second question is, how thick, what vertical thickness do we need around the implant? And this is important to understand the difference between the vertical thickness and the horizontal thickness. We will talk about the horizontal thickness afterwards. So, I don't know if you're familiar with, if you know Thomas Linkevicius. He has done quite a lot of work with this concept, and it's sometimes difficult to understand, and I will try here with some of the drawings to explain this concept. So here we have 2 bone crests. They are the same, they have the same dimension. But on one side we have a thick tissue, like let's say we have 4 millimeters, and on the other side this is thin, we have like 1 millimeter of soft tissues. And although there is the same quantity of bone, if we place an implant there, on the first one, you have enough thickness to have a proper biological width around the implant. You remember, it's generally 3 to 4 millimeters. So you need 3 to 4 millimeters of soft tissue around the implant to have this muco-integration establishment. If you have just 1 millimeter, this is not enough in thickness. So basically what you have then a physiological remodeling. It's not a remodeling that is due to bacteria, it's a remodeling that is due to physiology, because you don't have the space for the biological. So you have a bone resorption, and you have an apicalization of the soft tissue to gain this thickness. So basically it's an early bone loss, it's an early bone remodeling that may be problematic, because that might also be an open door for the colonization of bacteria on the implant surface that is moderately rough. Something you could do is On the second case scenario, you can also place your implant deeper. You can actually anticipate the physiological remodeling. That's another option. But you can also augment eventually the thickness of the soft tissues. But this is really something you have to basically diagnose well when you place your implant. So if the mucosa is really thin, and this is very often the case, for example, in the lower mandible, or you augment your soft tissue, or you place your implant deep, basically. Third concept is the horizontal thickness of the soft tissues. And here this relates more to aesthetic. I mean, now there is clear evidence and also lots of publications from a group from Belgium, from the University of Ghent, and they clearly emphasize that with thick soft tissue phenotype, with thick soft tissue, you have less gingival recession. So what do we do when we have a thin phenotype? What do we do when we have thin tissue? We can actually transform this thin tissue into a thick tissue. We will discuss that, but with microchirurgical surgery, you can boost basically the phenotype of the soft tissue and make them thick. And of course, this will lead to more stability, but also to better aesthetic. So to summarize a little bit this, what do we need to answer to this question? What is a proper periimplant soft tissue environment? We mentioned we would need basically 4 millimeters of keratinized tissue before placing your implant. We would need at least from the thoracic studies at least 2 millimeters of vertical thickness, but 3 is even better. If you have 2, you may then place your implant a little millimeter infrabony. And then we need a thick biotype, phenotype, especially if you're in the aesthetic setting. So we come to the next question. So then how to optimize then the soft tissue quantity and quality. So then we come to this first part of the lecture, so how can we do that surgically? And actually we need to think of that not only for the very complex aesthetic cases, but also sometimes for the simple cases. This is here a case of an edentulous patient. The treatment plan here is just to place 2 implant to retain a removable denture, but as you see, this is not so favorable. I mean, we have really a limited amount of keratinized tissue, so you can do these epithelial connective tissue graft to augment the quantity of keratinized tissue prior to implant placement, and then you have an environment around your implant that is much more favorable for long-term stability. Another example here, still in the anterior mandible. You see that this is very limited. You have the muscle fibers that can go quite high, and you can just do basically an apicalization of the insertions of these fibers and do like a little epithelial connective tissue graft like this. Let's see a case together. This is a lady, she's actually quite young, and she has significant resorption in bone resorption in the posterior maxilla. So definitely a case like this, if we want to place an implant, we need to augment the bone. But I don't like too much to augment the bone if I don't have proper soft tissues, because we would have to do some periodos release, we would eventually have a little retention. So in these cases, I always do, if we have a limited amount of keratinized tissue, I do my soft tissue augmentation prior to implant, but also prior to the bone augmentation, because here there is no way to place implant and regenerate in the same time. We have to first do a bone regeneration. This is a pretty extreme case, but see, I do here again an epithelial connective tissue graft in the posterior region. In the posterior region, it is a little bit more tricky than in the anterior region, because the periosteum is not properly adherent to the bone. You know, it's for example, when you do a wisdom tooth extraction or extraction in the lower mandible, this is very easy to release your flap, but this is actually the periosteum is not very adherent. So the additional difficulty from a technical point of view when you do this type of grafts, like free-gingival graft, epithelial connective tissue graft in the posterior maxilla, the additional difficulty is the periosteum. You need to be careful, because if you are, if you damage it, it's going to turn quickly in a disaster. So we will have a video later, I will show you. But you see how it heals. It heals really nicely, wonderfully, and you have also a thickening. I mean, when you go after the graft, it's always quite thick as well. So it's good, we have the quality and we have the quantity. And there I feel a lot more comfortable to do now my bone augmentation. So here I use a technique. I'm working a lot with guided bone regeneration in a bone defect that is not so favorable. Here, we had a knife edge defect. I like to mix the biomaterial together with autogenous bone, but I harvest the autogenous bone locally. I drill actually at low speed with a drill, low speed, and I collect the chips, little chips, and I do that actually now. I changed a little bit. We're not going to talk about bone regeneration, but I can say a little bit now. So it's low speed, but without irrigation, in order to not wash everything. Before I was using a bone trap, but the problem of the bone trap is that it's basically washing the chips of bone. So you're washing basically all the growth factors and all the good stuff you have in the blood and in the bone marrow. So now actually it takes a bit more time, you have to be a bit more patient, but I go at low speed and I collect chips with like my little spoon, with a little elevator. And then I mix that with the material, with the xenograft. We will talk a little bit about material by material selection later this afternoon. And then I work often with resorbable membrane, with a collagen membrane, at least if it's horizontal defect. Here we had, the defect was severe, but it was still horizontal. When we need to do a vertical augmentation, this is a lot more tricky. In these cases, I usually use a non-resorbable membrane. But in this case, I still decided to go for something resorbable, but it's less invasive, as you don't have to reopen everything to remove the membrane. So with this technique, as you could see, usually with this I had to wait like 9 months. With this technique, I could augment. I mean, we have an augmentation that now allows you to place an implant. This is not a huge augmentation. This is like a small one, but still able to place an implant. And when I place an implant, there I actually like to use narrow diameter implants, because if you augment the bone, I don't want to remove the bone to put titanium in there. So in cases like that, I usually go for narrow diameter. So here this is the true posterior mandible of this patient. The two sides. You see that I augmented both of them. And this is here the 5 implants. I don't always use 3 implants for 3 teeth. Usually, nowadays, in most of the cases, if I have to replace 3 teeth, I put 1 implant medial, 1 implant distal, and I do 3 implants for the teeth, a 3-unit bridge, basically. But in this case, because it was narrow diameter implants, and because some of them were short, I decided to put 1 implant for 1 tooth. I know that narrow diameter implant are not always recommended for the posterior maxilla, but here this was a posterior mandible, but here this was a case, you know, with regeneration that I didn't want to compromise, so I decided to go for that. It was a rock solid implant. It's quite old cases, but it was when this rock solid came out, it was just released on the market, and I can tell you that it still behaves really well. So this is just after the surgery, and you see now how my regenerated soft tissues are nicely adapted around the implants. Of course, here there is no reason to submerge the implants. I mean, I prefer to always work with a transmucosal abutment, because then you can push outwards actually the soft tissue. And this is here the X-rays of the restoration. This is a clinical picture. This is pictures from here, 4-year follow-up, but this is now more than 10 years, and actually everything is still behaving really nicely. I'm in front of the screen for those of you. Have to tell me if you don't see it. Yeah, here this is a 5-year follow-up. You see, I mean, the bone levels are really stable, and usually when the soft tissues are happy, the bone underneath is also happy. Another case here. You see, I emphasize the dental nerve here. This is a case where I have a limited amount of bone in terms of height in the posterior mandible, and I also have a limited amount of keratinized gingiva, keratinized mucosa. And in these cases, again, you know, there are tricky cases. I know in a case like that, I'm not going to do a vertical bone augmentation. You have to know that vertical bone augmentations, this is not as reliable as an horizontal one. This is very challenging, and in order that it works really well, you need really a bone peak in mesial and in distal. So if you don't have these 2 high bone peaks on each side of your planned vertical augmentation, it's not going to be successful. In a case like that, you know, you don't have it in distal. So this is a case really I would rather go for a less invasive approach and work with short implants. So in this patient, so I first did, as usual, you know, my soft tissue augmentation, the free gingival graft. This is a very effective technique to augment, the most effective technique to augment the keratinized tissues. So this is after healing. This is not always very aesthetic, you know. You can see it's a little bit like a patch, you know. But I'm very confident when I have tissues like that before placing my implants. And here again, I placed 3 implants, but this is a 6 millimeter, this is a 4, and this is a 4. So, you know, if you lose bone around a 4 millimeter implant, you're not very happy, because, you know, if you just have, you know, if you have a 2 millimeter bone remodeling, this is not good. So this is why, especially in these challenging cases, I think this is important to have the proper parenchymal tissue environment. And unfortunately, I think here I don't have the X-ray implant, but anyways. This is another case, you know, and I can show many of these, because especially the posterior mandible, I mean, this is very often that we don't have much keratinized genital. So yeah, let's look at this case together, because here I have a little movie, and then we can discuss the different aspects of the technique. So that was our former logo there, but now we have a new one. Anyways, so it starts with preparing the vascular bed. And here you do then a split thickness flap. The goal is to do your incision along the periosteum. So you leave the periosteum on the bone, and you release the muscle fibers in the flap. But you should not leave the muscle fibers on your vascular bed. You don't want to make a graft on pieces of muscles, you know? But you have to be careful to not rip your periosteum, and this is the most tricky part. So you go slowly, with a new blade. You know, when you do mucotransitional surgery, don't hesitate to use new blades all the time. So sometimes the video is a little bit on fast forward, so you take your time, you know. If you see me being fast, it's because it's fast forward. So once the vascular bed is prepared, this is quite easy. And you start the vascular bed at the mucogingival junction. You know, you just leave the existing keratinized mucosa, and you start your flap at the mucogingival junction. So this is now here the harvesting of the epithelial connective tissue graft. This is rather easy to do it. It's not as complex, for example, as the connective, subepithelial connective tissue graft harvesting. We will see that later on today. You design, you have of course to measure, to report your measure. If you want, you can also work with a little, I don't know how to say that in English, like like a little piece of paper, that you take from, for example, from your suture that is sterile, and you make, I don't know how to say that, but I think you understand what I mean. But anyway, it's really important to measure. And procedures like that, this is microsurgery. I would strongly advise to do that with some loops, with some magnification device. But when you use magnification device, you really have to measure everything, because you don't have anymore the proportion in your eyes. And it always looks big when you harvest, but then sometimes you come back if you don't measure properly, you come back on the vascular bed and it's too small. So as you see here, I always look outside. I control actually the thickness of the graft looking outside by the transparency of the blade. We want to have something that is like about 1.5 millimeters thickness. So then you place your graft, you check if this is proper dimension. You can still a little bit reshape it eventually on the side. And then you just have to do the sutures. I mean, just the sutures, this is a very important step, and it's also probably the step that takes the more time. So first I do some single interactive sutures on the surface, on top of the crest. You just do it with the existing keratinized tissue. I use here polypropylene when I do mucogingival surgery. Usually I like to use this type of sutures. This is a monofilament that is not adhering the plaque. So then here, that's probably the most important suture of the procedure. This is a sling suture where you take anchorage in your periosteum, and this is why this is very important that your periosteum is intact. And you have basically one chance, because if you start going several times, then you rip it and you're finished, you know. And then you see, I anchor it on the periosteum, and then you take you go over the existing keratinized mucosa, and this, you know, with this you're able to maintain the graft on your vascular bed. And you know, you have a pressure, like a pushing pressure on the periosteum. So when you've done that, and these you can do several of them. You know, you could do one, if you have a long graft, you can do one medial, one distal. And then you have, when you do that, you know, the computer, this last suture, first you remove the excess, you've seen before with the little scissors, you have to remove a little bit the excess of the flap, because you're grafting, so you remove a piece of the excess muscles, and you have to do a suture that is going to maintain the flap apically. Because if you don't, the flap may come over the graft and the result will not be optimal. So this is really, as you see here, important to keep the flap apically. And there you see that I've done two also periosteal sutures. So I basically suture the flap, you know, to the periosteum that is under the graft. And by doing that, because the periosteum is adherent to the bone, it brings the flap up and it keeps the flap up. And again, you can do one, but if you have a large one, you can do two. Okay. So, just for this case, I come back a little bit. And this is, you know, this is here after a few weeks. This is how I heal, and you see that I could nicely augment the dimension of the keratinized tissue. Now I have more than 4 millimeters, and I'm very comfortable for the next steps. So now the question is, when would you place your implants? When would you place your implants when you do that? And actually, when soft tissues, they heal quite fast. You know, you remember I told you for the bone I wait 6 to 9 months, sometimes 9 months for the severe defects. But the soft tissue, this is actually quite fast. So here, this is a little bit the dynamic of this. Within 3 to 4 days, you have already a revascularization of the connective tissue, of the tissues, and a complete revascularization at 7 days. So when you see a patient to remove the sutures, usually I do that between 1 week and 10 days, or 1 to 2 weeks, basically. When you see your patient, normally this is revascularized. This is basically red again. It might be that just the epithelium is desquaming. You know, sometimes you have some little epithelial cells that are a little bit whitish. This is not fibrate, this is just the epithelial cells going up. But then you have a re-epithelialization, you have an increase of the blood supply, and at 3 weeks you have the redensification of the collagen. And usually at 3 weeks, this is okay. You can actually go for your implant procedure. I usually wait 1 month, or sometimes 6 weeks, but you don't have to wait 4 months, so, I mean, this can be quite fast. I mean, in the overall continuity of your treatment, basically doing that type of procedure will just make the overall treatment like 1 month longer. Of course, there is one extra surgical step, but in the challenging cases, this is really important, I think. Something else I wanted to discuss also about the video is the choice of sutures for the sling suture. You know, the one anchored to the periosteum. So you've seen I like to use the polypropylene, but not for the sling suture, because the polypropylene, you know, it's a little bit, we say in French, we have a saying like the wire to cut the butter, you know? And it is a little bit basically cutting that type of suture. So these sling sutures, they are a little under tension, and I prefer to use a kind of softer suture for that. And you've seen here I've used some Vicryl, some basically resorbable material that is woven, so it's a bit softer. Another one that would be totally relevant is the Gore-Tex, you know, the PTFE, the polytetrafluoroethylene. These are nice because you can actually control better how tight the pressure you put on it. But just what I want to say here, you need to use a suture that is soft. And for the sutures, actually suturing the flap apically, there are sutures that are usually quite difficult to remove. You know, when you suture the alveolar mucosa, this is not very nice for the patient to remove afterwards. So this is usually why I privilege some resorbable sutures for these. So this is why basically I use the Vicryl rapid in these cases usually. So this is usually the 5-0 for the resorbable, for the Vicryl, but the 6-0 or the 7-0 for the polypropylene. But of course, when you work with 6-7-0, I mean, you need the magnification device. Actually, you need them. For me, this is mandatory for almost every procedure in plant dentistry. And if you don't have it, you don't know what you lose. But once you start to use them, you cannot go back, I can tell you. Is there any question about that? Because you see these procedures, I like them a lot, and you've seen them in different cases. We have another one here. And, well, one of the downsides is definitely the patch effect. You know, this is not very aesthetic. And you've not seen any of these in the upper maxilla, for example, or in the aesthetic zone. Of course, that would not be the strategy in the aesthetic zone. In the aesthetic zone, you would have a different approach, of course. And actually, in the aesthetic zone, the problem is not usually the absence of keratinized tissue. We usually have enough keratinized tissues in the upper maxilla. But sometimes we have tissues that are thinner, or we have retractions, recessions, and it comes here. What do we do in the aesthetic zone? How can we boost the soft tissue phenotype in the aesthetic zone? And for example, in a case like this one, this is a case where we have an ankylose of the 21. This is how you call the teeth here, the European way. So yeah, 21 is ankylose. We have infra position, and this is resorbed, so we need to do something. And we will talk this afternoon and tomorrow about immediate implant, but this is definitely not a case where I would do an immediate implant because we are in a not favorable condition, especially in terms of soft tissues. And actually, I like to do this little aesthetic analysis in the aesthetic zone before doing anything because it is really useful to, let's say, identify, to diagnose the challenge. What is the goal, you know? How much tissue do you need to reconstruct here? And then you can also inform your patients, okay, this is, for example, in terms of papilla, you can inform them that it's going to be very tricky and maybe not realistic. Here, I don't think it's not realistic, but I think we have to have a step approach procedure. So here, after extraction, I do a socket management. Again, we will talk about socket management this afternoon and we'll go into these details later on, but here I want to emphasize the soft tissue approach. So you see I took a large connective tissue graft and I put it like a saddle. We will see this video in detail afterwards. But the idea is to do a buccal pouch. and a palatal approach, and to really anchor your saddle connective tissue graft buccally, because this is especially buccally that we want to augment the thickness of the soft tissues, but you also have to go palatally to have the anchorage of the blood supply, let's say, from the graft. When you do mucogingival surgery, you really have always the key aspect for success. This is to think vascularization, to think blood supply. You need to have enough blood supply. And here, you know, in the socket, you don't have yet blood vessels. So you have a little bit of a gap of blood supply in occlusal. So this is why this is important to go buccally and palatally. But for this, it's true that you need quite a large graft. This is something we've been doing for many years, and we've done some research with this technique. It works really well, but it's true that it's quite a larger connective tissue graft. Now, sometimes I do the connective tissue graft at the time of implant placement, but we discuss that later. But it's interesting to see how it healed over time, and if you have done the procedure properly, if you have enough blood supply, if you have a connective tissue that is properly stabilized. And for example, I tell my postgrad when they do any kind of soft tissue graft, you know, after the procedure, you take your finger and you try to get it out, the connective tissue graft. If it gets out, it was not properly stabilized. But if it stays in place, we save. And you see, after 1 week, it's like already revascularized. You have a thin layer of fibrin. This is normal, but underneath you see that it's living, right? 2 weeks, it's in the process of reepithelialization, and after a month we have complete reepithelialization. So, and you can see that we still have kept the volume. So basically we know that, and we will talk about it again this afternoon, but we know that normally we have little bone retraction that is compensated by an augmentation of the thickness of the soft tissue. And this is how we are after 3 months. So you remember, we were initially here with the cervical level, at least 3 millimeter more apical. So now I am in good conditions. I am confident to place the implant. And of course, we could preserve the bone as well, and this is stuff we can discuss this afternoon. This is a technique we've been doing for many years. We have lots of data, like that was published already a while ago about that, about the bone profile, but also about the soft tissue profile. And we also have some long-term data that I will discuss further as well. So this is the before and after, and you say what is important to see here is, you know, this soft tissue, they are, you know, thick, stable, and I think here it's already the follow-up after 2 years, and I can tell you over time this stays really stable. This is another case, and I think this case I wanted to show you, just to show you a little bit the surgical technique and the video. So of course, all this starts with a careful extraction, with a minimally invasive extraction, and with a proper cleaning of the socket, proper debridement. Then the socket has to be intact, of course. When you do a socket management, when you have a rich preservation, you need to have bone everywhere. You should not have a fenestration or a descent of the buccal bone. When we talk about extraction socket management, we will discuss that in more detail. Also for the biomaterial selection, but here basically it's xenograft. You know, that need to be very nicely incorporated in the blood clot. And then comes over to the soft tissue augmentation. So you see, with a microblade here, but this could be with a 15C blade as well. You know, I do a split thickness poach. It's here I'm still remaining over the periosteum, because then we have a double vascularization, a double blood supply, the one from buccal and the one from the periosteum side. And of course, this is the area where we want to augment. This is the area where we want to tick. So it needs to be deep enough. So it needs to be, I would say, at least 5 millimeter buccally. You need to be above the gingival junction. So this is here the harvesting of the connective tissue graft. I will show you this afternoon some cases of the harvesting of this. Don't worry. You know, you place it in the pouch and you stabilize first buccally with some just single interrupted sutures. You could also have a suture that helps you inserting the graft into the subject. So here this is again the polypropylene. You see I work with microsurgical instruments. Another one. So it is also important to not tight too much these sutures, because the polypropylene, this is nice because it's a monofilament, you don't have too much plaque adhesion, but if you tighten too much you may have scars. And these scars, when you have them, this is really difficult to get out and to take out. So this will stay on time. And here, to be honest with you, this one is a bit too tight. So you need to find really the perfect tightening, I would say. Of course, all these types of procedures, they need to be done also on tissues that are not inflamed. So if you have, for some reason, an inflammation around the tooth you need to extract, I would always recommend to see your patient prior to the surgery and to do a cleaning. You know, for example, if you have a failure or fracture, you know, we know that it's a highway for bacteria, but you need to, you know, 1 week before the surgery, clean, remove the bacteria in order to decrease the level of inflammation, to be able to do a surgery in proper conditions. Surgery with on tissue, because as soon as you have inflammation, you have a destruction of the collagen, and you basically have tissues that are like super loose, and you cannot do a proper surgery. So I would like to show another case. Here is a full case with all the description where when using this technique. But I don't know, should we make a pause now? Because I see here that they started at 1 hour and a half.